Good evening, ladies and gentlemen, and welcome to our tonight's presentation by Mr. Lackson Jokonya. The presentation is titled Thyroid Ultrasound and Related Pathology. It's going to be a very informative and educative presentation, as they always are here. So I want to welcome all of you and encourage you to stay with us until we finish the presentation. We'll be able to ask questions at the end of the presentation, but also during the presentation, we may write our questions down in the chat room so that as soon as the presentation is over, we can try and answer and share knowledge on whatever question that would have arisen during the presentation. So let's sit. Okay, go ahead, Mr. Lackson. I think my network also wants to misbehave, but I think just go ahead. We can hear you loud and clear.
Oh, thank you so much. Well, my name is Lackson Jokonya, a radiograph technologist practicing from Senanga General Hospital in Western Zambia. Just want us to interact around thyroid ultrasound and related pathology. The objective of this presentation is actually just one, not more than one, to discuss the role of ultrasound in the imaging of the thyroid gland with its related pathology. Now, maybe we start with first things first, anatomy of the thyroid gland. Now, the normal thyroid gland is located in the anteroinferior neck or infrahyoidal compartment. It is divided into two lobes resting on either side of the trachea. The lobes are connected at their lower third by a thin isthmus that crosses anterior to the trachea. Immediately anterior to the thyroid are the thin strap muscles, the stenohyoid, sternothyroid, and omohyoid muscles. Lateral to the thyroid are the more bulky sternocleidomastoid muscles. The longest scoli muscles are just posterior to each lobe of the thyroid gland along the lateral aspects of the anterior vertebra. Now, because you realize that the thyroid is a very small, it's a small organ, actually. A small organ, but very highly vascular. And because of its high vascularity and how that vascularity affects the dynamics of the ultrasound imaging of the thyroid gland, it's important for us to highlight the vascular anatomy for the thyroid. The common carotid arteries are located lateral to each thyroid lobe, and the jugular veins are anterior and lateral to the carotid arteries. The superior thyroid artery and vein are found at the upper pole. The inferior thyroid vein is located at the lower pole. The inferior thyroid artery is located posterior to the lower third of each lobe. So the mean diameter of the arteries is 1 to 2 millimeters. The lower veins, it's 8 millimeters. The peak systolic velocities for major thyroid arteries ranges from 20 to 40 centimeters per second. Then the intraparenchymal arteries have a mean velocity, a peak systolic velocity of 15 to 30 centimeters per second. Now, in terms of instrumentation and technique in imaging the thyroid glands, we recommend a high frequency transducer of about 7.5 to 15.1 megahertz for deeper ultrasound penetration of about 5 centimeters. The linear array of transducers is preferred to a sector array of transducers for wider near field of view, as well as because of the ability of combining high frequency grayscale and Doppler images, producing high resolution. Due to the high vascularity of the thyroid, Doppler examination is indispensable to the procedure. It's a sin to do a thyroid ultrasound without Doppler, interrogation. This is because of what I tried to talk about, the high vascularity of the thyroid gland. Patient is usually examined. The patient is usually examined in supine with neck extended. For better evaluation of the lower pole, patient may be advised to swallow so as to momentarily raise the thyroid gland. I think that's very important. So the patient lies in supine with the neck extended so that it's easy to actually evaluate the thyroid, but it becomes more prominent if we try to do the maneuver of if the patient tries to do the maneuver of swallowing, so that it can raise the gland. So the thyroid measurements, I think this is very important. In adults, the thyroid measures for about 4 to 6 centimeters in length and about 1.3 to 1.8 centimeters in anteroposterior, or the width and transverse diameters. The transverse diameters. So the isthmus measures up to 3 millimeters in thickness. So thyromegaly is present whenever the transverse or AP diameter reaches beyond 2 centimeters, or when parenchymal, the parenchyma of the thyroid extends anterior to the carotid arteries. So the thyroid volume is calculated using the ellipsoid formula, where we take the measurements at 3 orthogonal planes, talking about the length, the width, and the thickness multiplied by the converter, which is 0.52 for each lobe. So the child volume range for the thyroid from 0.4 cc to 1.4 cc. Adult volume from about 10 to 11 cc. Take note that the thyroid volume is usually higher in patients with iodine deficiency, acute hepatitis, and chronic renal failure. We expect a raised volume for the thyroid due to the metabolism increase in these conditions or demands. Now, the thyroid pathology cascade, you look at the categories of thyroid conditions or pathologies, which can be congenital anomalies, so anomalies, diseases that are present on the patient at the time of birth or from the time of birth. You can also have nodules, which are a very common indication for a thyroid scan. You have thyroid parenchymal diseases. This is the cascade. Now, the congenital anomalies, One, though ultrasound plays a very minimal role in this particular case, we look at the thyroid ectopia or ectopic thyroid. We misplaced. So the ectopic thyroid could be located in the lingual thyroid, which forms between the foramen cecum of the tongue and the epiglottis. So there is ectopic thyroid tissue developing around that space. The other common sites of ectopic thyroid include the sublingual, the paralingual, intratracheal, and the infrasternal regions, and along the tract of the thyroglossal, glossal duct. Now, you can also have thyroid hypoplasia or underdevelopment of the thyroid gland itself, which can also be present at birth, from birth. It can also actually fail to form, can have a genesis or aplasia of the thyroids. But the other common congenital anomalies, we talk about the thyroglossal duct cysts, which develop between the tongue and the hyoid bone in the midline, actually. Now, this is the point where the thyroglossal duct cysts usually develop in the midline between the tongue and the hyoid bone itself. Sonographically, you would see there's some kind of a complex cyst with some solid components within that space. And you know it's a thyroglossal duct cyst. The thyroid nodules, which is a very common, like I said, common indication for ultrasound. So ultrasound can assist in distinguishing the benign from malignant disease by analyzing the presence of cystic versus solid elements, the degree of echogenicity of the solid elements, the existence of calcifications, and the regularity and definition of the nodule borders. So a constellation of typical features such as hypoechogenicity, poorly defined irregular margins, and microcalcification should increase the index of suspicion for a malignant nodule. Lymph nodes involved with metastatic thyroid cancer tend to become rounded and bulging, and they lose their HeLa echoes as the structure becomes disrupted. So cytologic examination of the fine needle aspiration, or FNA, is the optimal and gold standard diagnostic test when malignancy is actually suspected. Now, the thyroid nodules in this cascade, I'm trying to give a few hints on what would you expect in terms of benign nodules. So the first line there, row, is trying to highlight that aspect in terms of appearance, sonographically. Then in the malignant facet, you have certain features like I was trying to highlight from this slide. You have some nodules which will present with the cystic components. Also, you have some calcifications within the nodule. Sometimes also the margination. These are poorly marginated, sometimes wider, and they are taller. Then you also have some solid components. But in terms of, for example, if you're talking about follicular adenomas of the thyroid, you would see some, if you look at the ovary, you have some follicles. So you would see similar appearances, follicular appearances within the nodule. Then you have a high suspicion of an adenoma. You can also have some calcifications, and the shape, irregular shape, with those with digitation of cystic spaces, sometimes raises the suspicion. You could be dealing with a papillary, thyroid cancer. You could be dealing with maybe malignant nodular hyperplasia of the, of the thyroid gland. So the spectrum of appearances for the thyroid nodules, I think is what I was trying to highlight here. When you look at the first aspect here on this slide, you'll see that when you look at this image, there is they are predominantly cystic, nodules with small solid neural components, but there is only peripheral perfusion. So there's no intraregional perfusion or nodular perfusion. So you find this lowers the index of suspicion for malignancy. On the contrary, if you look at the other image here, you see the mixed solid and cystic nodules, with central macro calcifications. Now, calcifications in the nodule raise the index of suspicion for malignancy and should always ring the bells for us to be very, inquisitive and try to see if we can do other, tests to narrow the diagnosis. Now, the thyroid nodules, spectrum of appearances continues. You have in the benign category of nodules, you have, for example, you can have this solid nodule, just uniformly homogeneous, solid nodule, maybe this one is very unlikely that you have malignancy because the margins are smooth, and so you wouldn't really think of malignancy here. Now, I've briefly touched on certain aspects of the papillary thyroid cancer. Now, you look at this sonographically, you find you can have a nodule which is homogeneous, hypoechoic, it's entirely solid. But you see to also have, can also have homogeneous hypoechoic solid region that contains scattered micro calcifications. Sometimes, you can have a solid hypoechoic lesion with scattered microcalcification. I talked about this. Then you can have hypoechoic lesion with lobulated margins, lobulated margins. You can also have solid hypoechoic nodule that is taller than wider. Then you can also have solid hypoechoic nodule that is with a discontinuous rim of calcification, which is solid hypoechoic nodule with coarse calcification. Then have solid hypoechoic nodule with a refractive shadowing at both edges. Then you could do also when you interrogate this on color Doppler, you see there is intranodular or intraregional actually perfusion. Thyroid parenchymal diseases. Now, these you can have subacute thyroiditis, which is also called Decuvens thyroiditis. In this cascade, you can also have Hashimoto's thyroiditis. You can have also Graves' disease. Now, Hashimoto's thyroiditis, which is also called chronic autoimmune lymphocytic thyroiditis. You have thyroid tissue, in this case, being infiltrated by some plasma cells and also some lymphocytes. So they infiltrate and then produce some inflammatory changes, which automatically result in the enlargement of the thyroid. So the gland is infiltrated with lymphocytes and plasma cells, and a fibrotic reaction takes place. You know, there is also coming along with this is associated with hypothyroidism. Hashimoto thyroiditis is associated usually with hypothyroidism. You can also have one other aspect, which is it's very common, actually. It's very important to take note. Very common in women. And so on sonography, the gland is normal or enlarged in size and usually hypoechoic. Apart from being hypoechoic, because of the infiltration that is happening on the parenchyma of the thyroid, you have some what is called pseudo nodular, appearance. There are some nodules-like structures mimicking nodules that form in the parenchyma, which give it a bit of a non-homogeneous echo texture. Now, the multifocal lymphocytic infiltration can cause, like I was saying, micronodular appearance. Thin echogenic fibrous strands may be visible and can cause a mouth-lobulated appearance. Often the gland is extremely hypervascular because of the pathogenomic changes that are happening resulting from the inflammatory changes or fibrotic reactions that are happening. For example, if you look at the fibrotic changes that happen on the liver, sometimes they would form some nodules on the liver parenchyma. It's the same kind of scenario. Because of the inflammatory changes, there's a fibrotic reaction which will produce that nodular surface. Often the gland is extremely hypervascular. Then there could also be reactive lymphadenopathy, often coexisting with Hashimoto's thyroiditis, especially in the central compartment inferior to the thyroid. In the end stage, the gland becomes atrophic. Fibrosis leads to atrophy. It reduces the size of the organ. So in its chronicity, it ends in reducing the size of the organ. So you end up with atrophy of the gland as the final stage. Now, this sonographically is what you would see in terms of Hashimoto's thyroiditis. Of course, there is the hypervascularity, which you can even see when you interrogate the gland on color Doppler because of the pathogenomic changes happening in terms of the vascular architecture. You would see this kind of picture on color Doppler interrogation. Graves' disease, which is also called the diffuse toxic goiter. Now, Graves' disease is also more common in women than men. It's also an autoimmune disease like Hashimoto's thyroiditis. Just like Hashimoto's thyroiditis, Graves' disease also produces what is called or displays what is called the thyroid inferno on color Doppler interrogation due to the hypervascularity arising from the pathogenomic changes that are happening in the vascular architecture around the gland. So key clinical features would include exophthalmos, the eyes, popping out from the socket. You have nervousness. The patient presents with nervousness, anxiety, heat intolerance, tenders to sweat, tachycardia, weight loss, tremors, diarrhea, and pigment abnormalities are key clinical features. although Graves' disease tends to be more homogeneous. Remember, when you look at the parenchymal appearance in terms of Hashimoto's thyroiditis, I was saying that there is a diffuse, there is a nodular appearance, a diffuse nodular appearance of the gland. But with the Graves' disease, the parenchyma is usually homogeneous, but though there is the thyromegaly, but the parenchyma is homogeneous, conferring a thyroid inferno on color Doppler interrogation, just like we have with Hashimoto's disease, thyroiditis. I'm sorry. Now, what is key on these parenchymal diseases for the thyroid is that to narrow the diagnosis, you need to follow up with TFTs so that you are able to distinguish clearly between Hashimoto's thyroiditis and Graves' disease. You actually know that Graves' disease is associated usually with hyperthyroidism. We said Hashimoto's is usually associated with hypothyroidism. So when we have Graves' disease, you expect a few changes in terms of the hormones. We can have, especially the T3 and the T4. In the Graves, it's usually raised, it's high. If I'm not mistaken, I think in Hashimoto's, it's the opposite. So you need to complement a sonographic, evaluation results with the lab results so that you narrow the diagnosis. Otherwise, you can have a diagnostic. If you only depend on ultrasound, you may have a diagnostic conundrum. So maybe there is need to involve the other stakeholders. So this is usually the appearance. It's usually more homogeneous on grayscale. You can see the parenchyma is more homogeneous compared to the Hashimoto's case. The thyroid inferno is usually a prominent, a hallmark feature of Graves' disease. You see this high vascularity on color Doppler interrogation. Otherwise, thank you so much. That's what I thought I should share with you colleagues. If there are any questions, any observations, any corrections, we can, I think it's time for that. Thank you. Over to the chair. I hope it's within network.
Yes, thank you. I am here. Let me just mute the other. I've joined also on the laptop. Let me take the sound out. I can hear myself. Thank you, ladies and gentlemen.